Hello, everyone, and welcome to Families, Substance Use Disorder in the Courts. Is compassion consistent with accountability? I'm Carmel Shachar, Executive Director of the Petrie-Flom Center for Health Law Policy, Biotechnology, and Bioethics at Harvard Law School. Before we start the event, I want to first flag that it is part of the Project on Law and Applied Neuroscience, which is a collaboration between the Petrie-Flom Center and the Center for Law, Brain, and Behavior at Massachusetts General Hospital. So a big thank you to our partners over at CLBB. A few logistical things before we dive into the substance. We really want your questions. There'll be an opportunity for a Q&A with our speakers at the end. If you would like to submit a question, the best way to do it is to use the Q&A feature found in the meeting controls at the bottom of your screen. You're also welcome to join the conversation or submit questions on Twitter to @Petrie-Flom using the hashtag LawNeuro. Again, that's hashtag LawNeuro. By contrast, if you have any technical issues, the best way to get a hold of us so we can help solve them for you is to email petrie-flom@law.harvard.edu. Before I hand it over, I want to plug some of our other events. The Petrie-Flom Center has a really robust event calendar. In fact, we have an event happening tomorrow at about the same time. Everything that physicians might want to know about recent Supreme Court abortion-related litigation, but we're too afraid to ask. And then on Thursday, we have an event exploring psychedelics and trauma, which might be of interest to this audience. The best way to find out about our events is to sign up for our newsletter, which comes out twice a month, to read our blog, The Bill of Health, which looks to bring health policy conversations into your home in an accessible way. I would also strongly plug the CLBB upcoming events, news, and education programs. They do such fantastic work, and you can visit their website at clbb.org. With that said, I want to introduce the moderator for this event and the person who is really the genius behind all of this, and that is Stephanie Tabashnek, who is the Senior Fellow in Law and Applied Neuroscience, which is a joint position at CLBB and the Petrie-Flom Center. Stephanie, the floor is yours.
Carmel, thank you for that very warm introduction. I appreciate it. So I have to say this panel is definitely a treat. I'm joined here with Judge Beth Crawford, who recently retired from the Franklin Family Drug Court. The full name is the Franklin County Probate and Family Court, where she just did such incredible work that I can't wait for all of you to hear about. And the second panelist is Dr. Davida Schiff, who is a physician and the director of perinatal and family-based substance use disorder care at Mass General Hospital. And she's also an assistant professor of pediatrics at Harvard Medical School. So as I said, I'm extremely excited about this panel, and we're going to be tackling some of the most, I would say, vexing and complicated issues in family court. And very often we're sort of operating in our own professional silos. And this is sort of an exception to that. We have a judge, we have a physician, I'm a psychologist and attorney. So, we've covered a lot of, I would say, groundwork and sort of in terms of looking at this from very different lenses. And I think each of the lenses that we see is really sort of critical in understanding the full picture. So we're going to be starting with a vignette, Julie, and then we're going to hear from Judge Crawford, and then we're going to go to Dr. Davida Schiff, and then we're going to have a very rich and interesting discussion where we welcome questions from the audience. So for those of you who want to follow along with the vignette that I'm about to read, it is posted on the website, and the PowerPoint slide should also be available on the website following this presentation. So Julie is 4 months pregnant with her third child. She suffers from opioid use disorder and anxiety and depression. She has a history of childhood trauma, including sexual and physical abuse. Her oldest child, Abby, is almost 4 years old. When Abby was 2, the child's paternal grandmother petitioned the Probate and Family Court and was awarded guardianship of her based on her parents' return to injection drug use. Abby's father died of an overdose shortly after his mother obtained guardianship. The court decreed that Julie could come back to court to seek unsupervised visits with Abby when she could prove that she was no longer using opioids. But in the meantime, she would have visits at a supervised visitation center. The The visits cost $25 each, which she could seldom afford. Her visits were so infrequent, the guardian has petitioned the court asking that they stop on the basis that they are just too hard for Abby. Julie used heroin throughout her pregnancy with her second child, Mason, who's 18 months old. A care and protection case was filed after his birth, and he went directly from the hospital to foster care. He has never lived with Julie. The Department of Children and Families has now placed him in a pre-adoptive home and seeks to terminate Julie's parental rights. Julie is able to see Mason once per month when she can arrange transportation to the visits. The trial in his case is scheduled for September. Julie has not engaged in long-term treatment for her opioid use disorder or her behavioral health disorders. Her DCF service plan requires that she engage in treatment. She went to detox after Mason's birth, but left after a day. Her social worker gave her telephone number she could call to obtain a recovery coach and mental health treatment. She does not have a cell phone and was homeless after Mason's birth, so it was too overwhelming to follow through. She usually misses appointments with her social worker. A few weeks ago, when she found out that she is pregnant, her sister offered her a place to stay on the condition that she gets treatment. Julie desires to have a healthy pregnancy, but feels ambivalent about going to the hospital for treatment right now and is worried about how her current pregnancy will be viewed by DCF. So with that, I'm going to transfer the baton to Judge Crawford, and she's going to talk about the Franklin Family Drug Court and also a little bit more about Julie. So go ahead, Judge Crawford. And I think you're muted. That's okay.
I am so sorry. So I'm going to start by describing a little bit about what has happened with Julie. So as you've heard Stephanie read from the scenario, she lost custody of her first child through the probate and family court. That's where I was a judge. So in general, what would happen in these sorts of cases, DCF might be involved in Julie's life at this time, but once someone was given guardianship, DCF would no longer be involved in the case. In general, in these cases, the court will encourage the parent to get treatment, and just like the judge did in Abby's case, might condition unsupervised contact on being free from substances. Supervised visits that have to be paid for are very common. It's very common that people can't afford the cost of the supervised visits. And I'll tell you, this is certainly the way I handled these sorts of cases before I started the family drug court in Franklin County. I became a judge in Franklin County at the height of the opioid crisis. Just about every other case I heard every day dealt with substance use disorder. There were hundreds of guardianship cases being filed by worried family members, many cases filed by the other parent, worried about how the child was doing in a parent's care. So this is a very typical situation. And I did just what the judge did in Abby's case. But unfortunately, what happened is a number of young parents died. And I just felt like I was doing the wrong thing. This wasn't the way I should be handling these cases. So I was really lucky to be in a county where I worked with other professionals in the court who felt the exact same way I did. They wanted to do something different as well. I was also really lucky that we had a really robust opioid task force in the community that was developed as part of the crisis when it hit in Franklin County. So we had a lot of support services, and we were not all operating, we were starting to operate other than within our silos and talking with each other about some of these problems. So Chief Justice Carey said to us, yes, you can go ahead, you formed the first family drug court. So we did so. We were very lucky about a year and a half later to get a $2.1 million SAMHSA grant, which really changed what we were able to do. So that allowed us to provide a lot of additional services to our participants, and also allowed us to bring in cases from the juvenile court. I was cross-designated as a juvenile court judge so that I could hear the drug court piece of those. So I'm going to talk a little bit again about Julie's case. So as you heard, when her second child, Mason, was born, a care and protection proceeding was filed in the juvenile court by the Department of Children and Families. So Mason went immediately into foster care from the hospital. He never came home with Julie. Julie was given a service plan to address her opioid use disorder and was given contact information about how to do so. But unfortunately, this is a very typical situation. We learned that this is really not enough. You know, her substance use disorder and her lack of steady housing, the lack of a telephone just made it really impossible for her to do what she needed to do. You've heard from Stephanie Reed that she actually went into detox for a day, but only stayed a day. She didn't have the support she needed to stay longer. So unfortunately, you know, at this point with this third pregnancy, she's also facing a trial to have her parental rights of Mason terminated. So I'm going to talk a little bit about what would happen if Julie gave birth to her first two children in Franklin County after we formed the Family Treatment Court. So when Abby's grandmother filed for guardianship, chances are she would have done that. She would have been self-represented. We have a wonderful court service center in Franklin County that was very well versed in the family drug court and what was required to come into it. So chances are she would have heard about it the minute she came in to start the paperwork. She also would have heard about it when she came to the registry to actually file the paperwork. She would have heard about it again when she met with the probation office at the initial hearing. Chances are Julie would have heard about it as well. And she is likely to have been appointed counsel. I mean, that was really what I always did in these cases. If a parent was indigent, I appointed counsel immediately who was very well versed in the family drug court program and what it was all about. So, and I would also appoint counsel for Abby, who would also be well versed in it. So the likely outcome of meeting with that probation office in a situation like Julie's is that chances are everyone would have agreed to have her come in to the family drug court. Now that may mean that grandmother still would have had temporary guardianship of her, but the litigation would have gone on hold while she came into the drug court. So a similar process would have happened when Mason was born. So she would have appointed counsel. Counsel would have been aware about the family drug court. DCF counsel would be aware of the family drug court. Abby's counsel would be aware. So chances are they would be negotiating Julie coming in to the family drug court in Mason's case as well. So I want to tell you a little bit about what would happen if Julie decided and everyone decided to come into the drug court. So after we got the SAMHSA grant, Julie would have been assigned a case manager, a peer support worker, a family social worker, and a nurse. And this team would work together to determine the level of care that she needed. They'd help her with medication. They'd help her with the behavioral health services. They'd help her with housing. They'd help her get a working telephone. And this wasn't done with just referrals, or isn't done with just referrals. It's actually, there would be someone who would hold her hand and take her to each of these places that she needed to be to make sure that she had the best chance of engaging. The other thing that would happen with her is that she would meet other parents who were in the exact same situation she was and would have an opportunity to form relationships with them. And they would help support her recovery. The final thing that would happen is instead of coming to court every few months, she would come every other week to talk about her recovery. So as a court, a few things that we changed is we learned how to use non-stigmatizing language. Drug tests were never called dirty or clean. Parents who struggled on an outpatient basis were always referred to as needing a higher level of care, not failing out of drug court. We were aware that most drug court participants had high levels of childhood trauma, and we always tried to keep this in mind when we were judging and viewing their behavior. So we don't know how Julie would have done in the family drug court, but she would have had a whole lot of people to support her recovery. And in looking at our statistics for success in the drug court, statistically, she would have been likely to have been successful in the program. She would have had regular contact with her children. And in fact, an important component of the family drug court is checking in every other week when she comes before the court to see how the children are doing and reviewing what needs to be done in order for the parent to resume custody. Julie would have worked with the program's family social worker to learn skills to safely parent her children and also to understand her children's experience with substance use disorder. She would have been in the program for about 18 months before graduating. Every few months, she'd prepare an essay about aspects of recovery, and she'd read that before the court. If she found it hard to stand before the court to read such personal things, we had a comfort dog who was there available to her, a giant Saint Bernard named Donut, who could stand beside her while she read her essay. And then there'd be a graduation at the end. And graduations were really special because for many parents who came through the program, this was the first time they ever graduated from anywhere. So we wanted to make that as exciting for them, inviting their family members to join in. So as part of completing the drug court program, people are also encouraged to think about their futures. So many folks, as they're in the final parts of the drug court program, get their GEDs. They're often enrolled in community college by the time they graduate. Many of them go on to become recovery coaches themselves with the idea that they want to give back. And the idea with the program is to not only help them live without substances, but also to enhance their lives and to make their futures brighter. So I'm just going to end by telling you some really great news that we've just found out. And that's that the trial court was recently awarded a $1.5 million grant from the Federal Office of Juvenile Justice and Delinquency Prevention. And what this is going to allow is it's going to allow each county in Massachusetts to have a needs assessment. And it's going to allow some of the practices of family treatment court, the best family treatment court best practices to be taught to those courts. There will also be other family treatment courts or family drug courts established in Massachusetts. Hampden County will be one of them, one of the first sites, and it's hoped that there'll be 6 more programs. These will be in the juvenile courts, at least initially, and we hope at some point the probate and family court will be able to join with this as well. So thank you very much. And I guess we'll move on at this point.
Yeah, thank you so much, Beth. That was really great. So next we're going to hear from Davida Schiff. So Davida, take it away.
Great, thank you, Beth. That was really a wonderful highlight of all the work that you've done and how what's possible when you think about bringing people across disciplines together through family drug courts. So I'm going to shift and focus a little bit in thinking about the medical care that can support people who are in early recovery during pregnancy and parenting. And I'm really thrilled to just look through the set of participants who are here and see people from so many different areas, but also just to be invited into this room of all of you who have been thinking about this topic that I care very deeply about from a slightly different lens and angle. So I'm looking forward to learning from you all in the second part of this presentation. Okay, so I'm hoping over the course of the next 15 minutes or so to highlight the importance of a continuum of care for women and families impacted by substance use disorder across the perinatal period, to describe a multidisciplinary clinic that we've developed at Mass General Hospital that's aimed at caring for families impacted by substance use disorder, and then to explore ongoing advocacy efforts to reduce stigma and discrimination to birthing people with substance use disorder. To start, the evidence around providing comprehensive multidisciplinary care during pregnancy for people with substance use disorder is quite good. We know that there are improved both maternal and neonatal outcomes with lower preterm birth, lower placental abruption, and less fetal demise, so both improved maternal and infant outcomes, and that these programs are cost effective, that they reduce maternal and neonatal healthcare costs. There's actually a number of sort of models of excellence across the country that have been in existence for the last several decades that I've listed here, and some of the articles that have shown those outcomes are listed on the right. And the second is that medications to treat opioid use disorder are the standard of care in pregnancy. Just like they are for a non-pregnant person, we know that the use of methadone or buprenorphine combined with behavioral therapy is defined as the standard of care for treatment of pregnant people with opioid use disorder. And you can see all of the professional organizations and societies that have affirmed this statement. And this is really because pharmacotherapy is preferable to medically assisted withdrawal, because withdrawal is associated with high relapse rates, which risks poor outcomes for both mom and baby. We know that prosecution of pregnant people with substance use disorder drives them from treatment, and it risks poor outcome for both mom and baby. These are two professional guidelines from the American College of Obstetrics and Gynecology, as well as the American Academy of Pediatrics, which I was lucky enough to work on, that really highlights the importance of a public health response to substance use in pregnancy. Yet despite this, despite almost all professional organizations affirming the need for a public health response, we're seeing actually an increasing number of punitive responses from states to perinatal substance use. As you can see with this data compiled by ProPublica and the Guttmacher Institute on the left, is that the number of states that have equated substance use during pregnancy with child abuse, and on the right, those that have actually had evidence of prosecution for substance use during pregnancy being almost all states in the nation. And that there's really almost no condition that our society condemns more than a pregnant person or a parent who's using substances. This was a really beautiful editorial that the New York Times editorial board put together now almost 2.5 years ago, and they came to our clinic and met with one of our first patients to really highlight the sort of litany of assaults that pregnant women experience because of drug use. I want to make the point that pregnancy is a really motivating moment. So when we get back to Julie's case and we think about those 2 prior custody losses that she's had, and this incredible moment that she's in right now, where she's early in her pregnancy and really wants to make healthy choices for her and her baby. And that what we see is that actually people do, across all disease types, make healthier choices to improve outcomes for them and their baby. This is shown with opioid overdose rates in Massachusetts, that those overdose rates decrease as we get closer towards delivery. But what was really worrisome to me as a pediatrician and thinking about the health and safety of families is that those rates actually increased in the year postpartum, and that 10 to 12 months after delivery, those opioid overdose rates are higher than they were before pregnancy. This is a quote from our former recovery coach at Mass General Hospital, where she, I think, aptly said that the truth is getting through pregnancy is the easiest part. And it was really this data around the overdose and really thinking about how we support people, not just until they're no longer a vessel carrying a baby, but really after delivery, that led us to thinking about starting the Hope Clinic. So when I came to MGH about 4.5 years ago, there were a lot of different disciplines providing a lot of different services, but none of them talk to each other. And I think this is the analogy with what Judge Crawford just mentioned in terms of thinking about how we get all of these different people that are really invested in caring for this population to integrate the care to actually make it be patient and person-centered. And what we aim to do is develop a program with really 5 core components. The first is that we provide multidisciplinary co-located care that's integrated for mother, child, and her partner, that's longitudinal from the conception of pregnancy through the child's 2nd birthday, that it's low barrier in terms of accessing treatment, and that it's trauma-informed and welcoming. And what we learned is that it takes a village in order to do this across the perinatal period. And we have specialists in obstetrics, addiction, pediatrics, social work, psychiatry, nursing, recovery coaching, and then of course, administrative support in order to provide co-located care for families. And what we've developed is a high-touch model with wraparound support. So we have 3 clinic sessions a week, providing nurse care management, peer support, and patient services coordination 5 days a week. And then we have the benefit of operating within a sort of larger hospital system that provides backup for sort of urgent addiction needs or urgent pediatric needs or urgent obstetrical needs in order to support our families when they need something outside of our 3 clinical sessions. And that we've learned is that in a multidisciplinary model, that we really aim to support families through those challenging times. Yet, although we know that relapse is an expected part of recovery when children are involved, everything's actually a little bit trickier. And so it's been really important for us to have open communication with our community partners and providers, whether that's a residential treatment program or the Department of Child and Families caseworker. And then whenever we need to have these tough conversations with DCF, that we do that together with the patient. And then finally, one thing that we've really worked hard to with our medical home is to promote shared visits of the dyad following loss of custody. So that should loss of custody result because of concerns for child safety or well-being, that the parent actually comes back when that child comes back for their routine care or their follow-up care, and it's an opportunity then to engage them in their own addiction treatment services as well. So I wanted to come back to Julie for a second and think a little bit about our current mandated reporting policies at time of delivery. So in this third pregnancy, Julie really was able to take the motivation that she felt to have the healthiest pregnancy for her and her baby, to abstain from non-prescribed substance use. She engaged in a multidisciplinary program where she's been able to get obstetrical care, addiction care, and mental health care. She's been housed in a residential treatment program, and she's engaged fully in prenatal care without concerns of a return to use. And so her last non-prescribed substance use was early on in her first trimester. At delivery, a 51A filing for child abuse and neglect was filed with DCF for delivering an infant with in utero buprenorphine exposure. So I wanted to just go through the actual legal language of the Massachusetts 51A statute. I am not a lawyer, and so this is an area that is many more of your expertise than mine, but we deal with this on the day-to-day basis and thinking about the interpretation. So the 51A statute I've clipped for you guys here, but a mandated reporter is one in his or her professional capacity has reasonable cause to believe that a child is suffering physical or emotional injury resulting from, and the third clause is physical dependence upon an addictive drug at birth. Our Department of Children and Families interpretation of the statutory guidance in Massachusetts has further guided mandated reporters to file a 51A when maternal infant dyads are exposed to prescribed medications to treat opioid use disorder. And that's from a circular that went out in 2016. I wanted to offer to you some of our patients' perspectives on this mandated reporting. And this is from research that's forthcoming of a qualitative study understanding pregnant and parenting people's experiences taking medications to treat their opioid use disorder. And their words are much more powerful than anything of mine. The first is that it's a flaw that the system just automatically assumes that because somebody is on buprenorphine or methadone, they're doing something wrong. It creates an awful stigma having that time after you have your kid be interrupted by DCF. I got home from the hospital to a DCF worker. It was horrifying and not appropriate. They don't do that to moms that are on any other type of medication. The next was someone who said it's crazy because I was looking at my paper, they put neglect on there. Why would they label it like that? She didn't have anything in her system when she was born, just the buprenorphine. Additionally, one said they put my name on a registry of child abusers, all for taking a medication that I wasn't allowed to get off of. And finally, I definitely think that if you've done something in your history of parenthood to show that you are not fit to be a parent, or you show that you're not safe, or that you put your child in harm's way, that warrants an investigation or a case. In our situation, again, I'm not trying to sound boastful, but I did literally every single thing right from the second that I found out that I was pregnant. So I want to offer several different ways that I think that there's a problem with our current interpretation of the 51A statute in Massachusetts. The first is that it's stigmatizing to women who are receiving the recommended treatment. Similar to what one of our patients shared, that in no other medical condition, such as treatment of depression or anxiety during pregnancy, do we stigmatize women who are receiving the recommended treatment by their doctor. The next is that it harms the health of pregnant people and their infants, because we know that this mandated reporting results in people avoiding the recommended care for them and their baby. Finally, it falsely conflates prenatal substance exposure with child abuse. And the final thing is that it's really discriminatory towards the birthing person, that are often women who identify as women, and that we don't have the same mandated reporting policy when there's a partner who's using substances or may be in recovery and receiving addiction treatment. There is a current act that's in the House. It's H221, and I just wanted to end my time with letting you guys all know where this stands. Rep. Garballey is the one that initially put it through. And what it would do is essentially create a dual notification system. So if you have an infant, like Julie's third child, who was born with in utero substance exposure to a prescribed buprenorphine, if there were concerns for abuse and neglect, and so those would be things like untreated addiction or active non-prescribed substance use throughout the pregnancy, then that's clear. There's safety concerns about the health and safety of that child, and that's a 51A report, as you currently would do, to the Department of Children and Families. But then there's another track where we know, because of CAPTA CARA requirements, that we need to identify these individuals and notify the federal government of a substance exposed newborn, and that could be individuals that were exposed to medications to treat opioid use disorder, whose parents were engaged in addiction treatment, stable in recovery. That would result no longer in a 51A filing of abuse and neglect, but an anonymous notification of infants with in utero exposure to another agency proposed to be the Department of Public Health. So what this would do is bring Massachusetts policy in line with the rest of New England while meeting federal requirements. We are the only state in New England that requires mandated reporting for the use of prescribed medications to treat opioid use disorder. Providers would no longer be required to file a 51A automatically by their singular fact of prenatal substance exposure, and instead an anonymous notification system would be developed. And this could go through an agency like the Department of Public Health. This has been sort of the course that this bill has taken. Last, it went through the Joint Committee in June, and it was reported out favorably in November. And I think it's hopefully in the moving forward stages, although it's hard to always know what the next steps are. And so before we open this up for discussion, it just felt important in this day for those of you who have also been touched by the enormous loss of the sudden death of Dr. Paul Farmer to share one of his quotes as we then begin to talk about how to improve the care for families impacted by substance use disorder. And of the many things that he really championed, he is quoted with the idea that some lives matter less is the root of all what's wrong in the world. And I'm so excited to now talk with you a little bit about how we elevate and support the care of families impacted by substance use disorder. So I'll stop my share.
So thank you, Davida. That was really, really helpful. So when both of you were talking, I was, really just struck by the really important cutting edge work that you both have done. And, all three of us have sort of talked about how we exist in our own sort of professional silos and generally in this field. And both of you are sort of an exception to that. And I was just curious, in thinking about your collaboration across disciplines, how do you think that that's enhanced what you do and led to better outcomes? And also, what additional collaboration do you think would be helpful given each of your sort of unique lenses? And I know that's a big question, but.
Well, I'm happy to jump in if you'd like. I think what was so important for me was working with a staff that felt the way I did about this. So within my court, I worked with people who were office staff members. I worked with probation officers. I worked with court officers. And we all, as a court, experienced the death of parents from overdoses. And I think that was a very hard thing for all of us. So we were very much on the same page as a court. I think the same is true as a community, because of course we needed to work with both the legal community, with DCF, with the treatment community. So I think that made such a difference. We were also really lucky in Franklin County. There's been a long and rich history of agencies working together, going back to the 90s. So I was really lucky to come into that county. I think this might have been harder in other places to start the very first one without this community and cross-discipline collaboration. But those are the things that really made it work for me.
I think it's really important to like level set that everybody actually has the same desired outcome, that everybody wants the best outcome for this mom, baby, partner, family, and that people have different lenses and approaches for how we get there, but that if we all keep that common goal in mind, then we can actually, I think, both better understand each other's perspectives and develop trust. And so much of what's been required for us building across systems and silos of care within the healthcare system has been trying to reach out and develop trusting relationships to help people understand about that common goal and vision. And I think that's what's allowed us to hopefully build small inroads and continue to be successful.
And Judge Crawford, you've talked today and in the past about building a sort of strong relationship with the Department of Children and Families in your jurisdiction. Can you say a little bit about how that trust was built and how that relationship was established and what benefits that yielded to the families in these cases?
Sure. I think it starts really with the head legal counsel in the West. She was very much on board and worked very hard with us to establish this program. So her leadership made a huge difference with the department. We were also really lucky to have one of the substance use disorder specialists for the department at the table with us. She was part of our team and part of our planning team. That made a very big difference. And then finally what happened is when we were able to get the SAMHSA grant, the family social worker worked very closely with the department to develop with individual social workers to develop a trust with them. And amazingly, what came out of this, and which was an unexpected benefit, is that, of course, we have mandated reporters at the court. Our probation officers are mandated reporters. And when we would have a parent who returned to use while they were in the program, who had custody, they would have to file a 51A. But it changed how it was filed. It wasn't just reported. There were recommendations. The team had already worked with that parent to talk about a higher level of care being needed and finding a residential treatment program for them to go into with the baby. So those relationships were so incredibly important because many times when a parent returned to use, the child didn't have to leave that parent's custody for very long, if at all, and they would go right from the program to a residential program. So that was really a wonderful thing that happened as a result of these relationships and these trust relationships that were able to be formed between the court, the program, and DCF in our community.
That's so helpful. And, one of, I think, the challenges, at least in my work that I see, is that that parents will, at various times their motivation will wax and wane, which is part of addiction, to get treatment. And so they'll enter into some sort of waiting list. And, by the time that, maybe a week later, 2 weeks later, the motivation has changed, or a bed is no longer available. And so what have you done to sort of overcome just the significant treatment shortage? And this is a question for both of you, when parents are, asking for treatment and it's not available because of the limitations in our systems?
Well, I think one of the things that is helpful in light of waiting lists, things like that, is really having the peer support person there. So if somebody, our team, I think, was very perceptive about someone who might be running into a problem. They could anticipate it based upon changes in their behavior and would just provide more and more supports. So having so many members of the team available, there'd be someone to have regular contact with that parent while they were waiting for the next step. And also to be able to support that parent and help them understand and refocus their thinking, and really help them focus on the relationship with the child and try to get them over some of these rough spots. But that took this great team. That was part of it, is we had just this amazingly well coordinated, trained team that worked hand in hand with our probation office. So hopefully that can be replicated, because that was a really important piece of this.
I want to add that I think until we've created a system that makes it easier to get into treatment than it is to buy drugs, then we're failing our patients, right? They're not failing the treatment. The treatment's failed them. So that if it's our responsibility as healthcare providers and public health practitioners and the legal advocates for them to actually say, we're going to design a system that gets you the care that you need, not asking you to jump through 16 more hoops that are impossible for any human to jump through in order to prove that you're ready for treatment. That whole treatment system and approach needs to be reevaluated.
Davida, I think that's a really important point. And when we talked about the vignette of Julie, and the provider who handed her a list of therapists to call. I mean, I'm a psychologist who knows a ton of people in the field, and just, anytime I'm asked for a referral, it's really challenging. It's hard to find a therapist, and even though I know the system, it's challenging. So I just can't imagine what these parents go through in terms of when they actually want treatment. You call 10 providers and no one is accepting new patients. So Davida, for you to say what you said, and you're embedded in a hospital, and you would think, okay, there'd be more access to treatment. I think it really hits home the reality that there's such a lack of, options for people who do want treatment. So, Davida, one thing you talked about that I was really struck by is the mandated reporter statute. And then in terms of, just when people are prescribed buprenorphine or Suboxone. And I find that really interesting that, that providers are, need to report, especially when we have drug testing that can distinguish between buprenorphine and heroin and fentanyl. And there was a question from the audience about how being a mandated reporter sort of impacts your role at the Hope Clinic. And, I think, more specifically, how does that impact building trust and your clients' ability to disclose what's really going on in their lives?
Yeah, thank you so much for that really excellent question. If I'm honest, I think it's one of the things that we struggle and grapple with the most, and that has been one of the most exciting but also challenging things about providing multidisciplinary care. So how do we hold those best interests of both the family and the baby together at the same time? I think this speaks to another question that came through into the chat as well, that in some cases the interests do diverge, and that there are parents who need at that moment to have a respite from caring for potentially a very difficult and fussy infant who has increased needs, while their parent focuses and works on their recovery. What we have found is that if we can engage people as much as possible in the process when a mandated report is necessary, so as we said, bring them into the conversation when a filing happens, they see what goes down in writing, they see what our recommendation is in terms of an engagement and sort of treatment escalation, that leads to the best success and kind of continued engagement overall. And the other thing to just note is we really feel strongly that a positive toxicology test is not a parenting test. And that doesn't actually say whether somebody has the ability to safely and effectively parent. And so we've taken the extra step in our clinic to say, when either self-report or a positive toxicology test comes back of non-prescribed use, we assess sort of several domains to think about that infant and family safety and well-being. And one of those is a willingness, an understanding of how and what the drug use patterns are, where that infant was or child was when that drug use happened, their willingness to engage in an escalated or step up level of treatment. And all of those factors go into play when deciding whether a mandated report is necessary. So it's having your patients know that if relapse is really part of recovery, and we know that, in addition to thinking about a plan of safe care, what would it mean to think about a plan of safe use? One of my colleagues that works at a family home visiting program that does child parent psychotherapy just kind of coined that term that I think is really apt and important. And in our work together, if we're really going to say that we understand addiction is a chronic relapsing brain disease, then we need to prepare people for it, not just hold them with unreasonable expectations should and when return to use happens.
I think that's a really good point. And we have a number of different questions coming in. And one question, which actually we were just talking about this before the panel, and it's one of my sort of gripes when it comes to parent-child contact is when children are removed from their parents, parenting time is often limited to either once a week or once every other week. And, one thing that Davida and Beth and I were talking about is that this is really problematic, especially for children who are within the zone of attachment, because for those children, they need to see their parents more frequently. And when we sever an attachment or interrupt the bond that a parent has with a child, this really causes significant changes in the brain. And some of this damage is sort of irreparable. So the question is basically, sometimes when children are removed, they'll see their parent once a week or once every other week for an hour in the DCF office. What recommendations do you have for DCF regarding parenting time with newborns?
Well, I'm happy to jump in on that and just say that this is something that concerns me a great deal. And part of the reason I really wanted to have a family drug court was to try to keep these babies with their moms. And one of the ways I think to do this is to work with programs like the HOPE program. If the department feels the need to file a CMP following a parent's involvement in a program, following mom's involvement in a program during pregnancy, then having her come into the supervision of a drug court, I think makes all the most sense. And keeping the baby with her so that doesn't happen, because it's just so hard. I mean, frankly, in a case without substance use disorder, it is so hard to do a parenting plan with an infant, especially with a breastfeeding mom. It's really hard. So these are just next to impossible. So I always find if there's a way to keep the baby with the mom or with the parents, that's what we need to do.
Davida, do you want to add to that by chance?
Yeah, I think the more contact that families are able to have with a child, particularly in the setting of custody loss, is like the most important thing that we can offer them to maintain and sustain their motivation. We see this at time of delivery where care and protection is filed, and then while awaiting the 72-hour hearing, they're told that there can be no visitation unless it's with a supervised visit by a DCF worker. And we really feel like that just destroys that important moments of potential attachment in that, first week of life, that in some ways, I don't know, it's irreparable harm that I think we together, our medical system and our legal system, thinking about what really are the risks to that, is just for this very small window of what happens immediately after delivery. Like, how could we, instead of trying to create hoops to say we want, again, these parents to jump through, what would it look like if we did everything we could to try to make sure that that unit and that dyad stays together? And I think we'd come up with a slightly different approach.
Yeah, I think that's a really great point. And I would also say just, one resource, the Association of Family and Conciliation Courts has a shared parenting guide. It's called, I think, the Arizona Shared Parenting Guide, and it talks about sort of acceptable parent-child contact based on the child's developmental age or, age. And, for newborns, really, you're looking at pretty much every other day. So 1 hour a week is completely unacceptable. And that's really true up until about age, 5 or 6. So we want really, frequent contact between parents and children to promote healthy attachment. So we have a couple questions. So this question always comes up, and Beth, I know that you've grappled with this a little bit. So in terms of, and the question was really on legalization of marijuana, and but I think in general, how do you deal with cases where there's maybe a parent is using marijuana in front of their child, or maybe they're in recovery from all of their substances, but they're still using marijuana. And I've seen this often in my work. And I've seen children who are not being returned to their parent because the parent is continuing to smoke marijuana, say in the morning and evening, even if they agree not to use it in front of their child. So any thoughts on this? And have you seen this in your work?
Sure, and that's something I absolutely grappled with, no question about it. And I certainly learned that there are all types of recovery, and total abstinence from all substances is not always the right route for everyone. And what I found, especially in working with a population with a high level of trauma, that total abstinence wasn't always the best route. So I took the approach with both alcohol and marijuana, that was not a reason to be punished or treated any differently at the beginning of the drug court. But my main goal was to prevent deaths, prevent overdose deaths. So if a parent continued to use marijuana and used it, it was buying it safely, not using it around the child, not storing it around the child, I was okay with that, with those parameters. Then trusting as the parent went through the program, trusting the treatment team to really talk to the parent about abstinence, about going forward. How is marijuana being used? How is alcohol being used? Is this something that you really want to continue doing in the future? Can you safely do this? That may not be the approach of every judge who does this, but as I said, my main goal was to prevent overdose deaths for these parents.
Davida, what about you? I'm sure you see this in your practice as well.
Yeah, I think there's so much about cannabis and pregnancy and parenting that is definitely a conversation for another panel. Maybe we can be invited back to talk about that. I do think that we have to balance in sort of this idea of harm reduction. So I'm just going to give you the example of cannabis and breastfeeding. We know that there are likely harms to consistent cannabis use and providing breast milk to babies in terms of long-term neurodevelopmental outcomes. How do we balance the advice to recommend that people decrease or abstain from cannabis use with the advice that we know that breastfeeding provides a whole host of important benefits? And how do you hold both of those recommendations? And so I try to actually do just that, which is what the American Academy of Pediatrics currently recommends, that we really do work with patients to say that abstaining from cannabis use is the most important thing that you can do in order to make sure that your breast milk is the safest and healthiest for your baby, and espouse all the sort of benefits about breastfeeding so that people get both and you support them to start that breastfeeding while decreasing their cannabis use.
Thank you. I think that's really helpful. And we're getting a ton of questions. A really important question just came in, and it's on sort of how structural racism works in terms of targeting moms with OUD. And, I just want to say I work in both juvenile court and probate and family court. And in juvenile court, I tend to see and evaluate parents who have less access to resources and tend to be women of color. And then in probate and family court, I tend to see people who are, have more resources and tend to be white. And the treatment for the pretty identical behaviors is vastly different. And I was wondering, from your perspective, based on this question, how have you seen sort of structural racism play out in your work, and what suggestions do you have for sort of countering this within the system?
Yeah, Beth, do you want to describe it first in the legal system to follow on Stephanie?
Sure. We work closely with a national organization called Children and Family Futures, and they assist family treatment courts, family drug courts throughout the United States. And this is a big issue for them. So they encourage all treatment courts to really look at your statistics and really look at these issues. Look at the community population. Are we serving the people we need to be serving? Are there different barriers to someone coming into the program because of race? So I think that's where we are at this point, but I think it's an incredibly important question and an important thing for us to be aware of at all times. And essentially what Children and Family Futures said, don't just sit back and kind of skate through this and feel like, hey, we've got this. Always be looking at your data and be challenging your assumptions about things. So I think that's probably the best thing for a family treatment court or a drug court to do, is to really follow the recommendations of Children and Family Futures and seek out their assistance with these sorts of things.
Yeah, I really appreciate this question. I was thinking about how it was sort of an omission of us to not really, from the sort of forefront of this talk, describe how structural racism really very much impacts the care that our families receive across these multiple systems. And there's no system that is spared from that. It's everyone. Within the medical system, one thing that we've been thinking about a lot is to broaden your question, not just to opioid use disorder, but really substance use disorder more broadly, is how does toxicology testing and then subsequent reporting and potential loss of custody at delivery happen disproportionately. So thinking about how hospitals really reevaluate what their toxicology testing policies are, particularly, so to bring up the example of cannabis, we know that women of color are disproportionately tested for cannabis compared to other indications. And that may be the only thing that gets them into that sort of toxicology testing, social work assessment, subsequent DCF filing, and potential then investigation that raises these other concerns that may be disproportionately provoked. Despite us knowing that actually there's not disproportionate use of cannabis when we look at national prevalence studies, but that women of color are more likely to be tested for it. So it's a really important question and a really big issue.
Thank you. So I have a final question as we're wrapping up. So we know from the research that compassionate approaches, including compassionate approaches in treatment, and from the bench, as Judge Crawford did in the Probate and Family, the Franklin County Drug Court, that the compassionate approaches lead to better outcomes for people who have substance use disorders. And, I'd say in my own work, some of the best parents that I know are in recovery, and they're working every day to make up for what happened when they were misusing substances. And my question to you, to both of you, is what role do you think that compassion and empathy have in your own work with this population?
I'm happy to go first. I was very aware of the privileges I had. I became a judge. I went to college. I had a relatively trauma-free childhood. And I really recognized those privileges and tried to be as empathetic as possible with the people who appeared in front of me. And it was very clear to me that these parents who came into our program with substance use disorder had long trauma histories, like Julie did. And I just would always say to myself how lucky I was. I could have very easily been in that same situation, and how would I want to be treated in that situation? Being a judge in general, you don't have much of an opportunity to form relationships with the people who appear in front of you. Usually most hearings that are non-drug court hearings last minutes outside of the trial session. They last minutes. You are making decisions about people very, very quickly. The wonderful thing for me about being a judge in the family drug court was I had a chance to have these parents appear in front of me every other week, and I had a chance to talk with them. I had a chance to know, I formed relationships with them. I knew what was happening in their lives. I knew what they were struggling with. And that was the most wonderful thing ever. And I feel like it was the best thing I did as a judge was to have this model. We have, and I didn't talk about this much, but this is another thing that we could talk about forever, is the whole system, the litigation system for families. It is just such a difficult way for judges to make decisions. It pits parents against each other. I was thinking about in the example with Julie, when the grandmother of Abby came in, because they were set up in a litigation situation immediately by that case being filed, they were in a difficult position. So, and a difficult with their relationship. I mean, would it be wonderful if they could just could have cared for Abby together rather than having to involve the court system? So I think there are lots of issues out there, and I appreciate this particular question. I think it's something that judges struggle with mightily.
Thank you for that, Judge Crawford. And Davida, we're almost at time. So if you could just share your thoughts on compassion, and then we will wrap up.
I will be super quick. I think my colleague, Dr. Sarah Weekman, who's the medical director of the SEDS initiative at MGH, always says that the most important thing is being authentic, humble, and curious. And I think ending with that, those concise, brief words, and echoing what Beth said, and hopefully will get us to move forward. Thank you for allowing us to have this conversation together.
Okay, thank you all. Thank you, Judge Crawford and Dr. Schiff, and thank you for the wonderful questions. And I look forward to seeing you all at the next event. Take care.
Great. Thank you very much.